Ganesh can share my screen. I'm going to be talking about hearing assessment in infants. I've been working here at KEM since the year 1993, and we set up the center called Big Ears in about 2006. The center Big Ears actually focuses on early intervention and, in children with hearing impairment and with communication issues. So when we look at my presentation, next slide would be, I would like to acknowledge these people who have contributed to making this presentation possible, especially the last Department of Neonatology and Pediatrics. When we started this universal neonatal hearing screening program here, it wouldn't have been possible without their support. And the presentation that I will be making is thanks to all that they have helped us with. What I intend to be covering in this next half an hour is basically going to be three things. The major part is going to be why and how do we have to assess hearing. If time permits, I will present our results that we've collected over the last decade, and of course, the pitfalls and challenges that we faced while setting up this service here in our hospital. Most of you may be already aware of these statistics, but it always is something that I'd like to start with. Not very many of us are aware of the fact that hearing loss today is the most common sensory deficit and not blindness, as we are led to believe. The statistics of WHO updated up to 2018 now tell us that we have about 466 million people in the world who have disabling hearing loss, and 34 million of them are children. It is the second most common cause of years that a person may live with disability, the first being orthopedic issues. What's important to us from a Southeast Asia aspect is that about 6.3 Indians in our country would have about significant hearing loss. That comes to about 63 million people. And 291 of these per lakh population have a severe to profound hearing loss, which means even certain devices may not help them as far as getting hearing is concerned. What I'd like you to note is that if we do not actively do something about it, this is what is projected by WHO is what's going to happen by the year 2050. The gray area is what is South Asia. And if you look at it, by 2030, we are anticipating we are going to be about 176 million people. And by 2050, we are going to have about 267 million people who are going to have hearing loss in just Southeast Asia. Now, coming to today's topic, which is mainly the prevalence of congenital hearing loss. In India, in our country, it is one of the most common disorders at birth. About 5 to 6 children out of 1,000 live births have some sort of a hearing loss. And this is twice the number that you see with congenital hypothyroidism or phenylketonuria, both of which are something that we screen most children for. The reason for this is definitely endogamy, which is our age-old tradition in this country and in very many other countries of marrying within the same caste and subcaste, leading to high degrees of consanguinity, which lead us to this problem. We have about an estimated 3.8 million deaf children in our country, and I'm sure it's much more now because this number that I'm quoting is from a study as far back as 2004, and we haven't had a recent assessment for very many years. However, we have about 30,000 children born every year in this country with some sort of hearing impairment. What troubles me most is the last one, which is that the average age of diagnosis in our country is about 24 to 36 months. That means the child would actually reach us for some sort of diagnosis or intervention by the time the child is about 2 to 3 years. And that, as we know, for most of us who work in this field, that this is nowhere near early. On the other side, I've just shown you the statistics as in what is the incidence in the USA, and as you can see, that's much, much lesser as compared to our country. Again, coming back to statistics, when you look at the prevalence of disabling hearing loss in children, as you can see, South Asia, which involves India, is way higher than any other part in the world. We have a prevalence estimated at about more than 2% in our country. The real picture thereby is that India, with a population, and again, this is 1.18 billion and growing by the very second, we would have about 12 million hearing impaired. More than 30% of these are less than 14 years of age. The infrastructure for these children, which would be giving them special education, we have only about 900 registered special schools. So if we were to send all these children to special schools, only about 3% of these children would get some sort of education. So we have to work at getting these children into mainstream education. Taking you a bit back into physiology, which is very important, when we look at the hearing brain, the part of the brain that's responsible for hearing has about 100 billion nerve cells, 10 raised to the power 15 connections or synapses that help us hear, understand cognitively, and speak. And it's influenced by as many as 1 lakh genes. The hearing brain basically is contributed or influenced by 3 things. The first being our genetics. It's our genetic makeup that's going to determine how plastic or how much the ability of our brain is to pick up and grow. What is going to maintain the brain in its activity and in its plasticity is going to be the influence of the environment that the child lives in, which is the environmental signals. And what is important for both these above points is the critical period as far as neural plasticity is concerned. When one looks at genetics of hearing loss, we know today, and this comes from the Central Diseases Control of the USA, is that 50 to 60% of hearing loss in children, at least in the developed countries, is genetic. However, I would say in countries like ours, which are labeled as developing, a lot of the hearing loss in children is actually due to some sort of a perinatal insult or infections. And the one that we are seeing very now common is CMV. But that being outside the scope of today's presentation, I'm not going to be stressing too much on that. 70% of these are non-syndromic and 30% are syndromic. Why this is important? That means 70% of these children are not going to be picked up by the family. What's even more important is 75 to 80% of these are autosomal recessive, which means the parents are normal. So again, the ability of a family to kind of look out for this is less. 15 to 20% are autosomal dominant, 5% are X-linked, and 1% are related to mitochondria. As far as the critical period for developing hearing, speech, and language is concerned, it's the first 3 years of life. That is the most critical period, as in almost every other thing, but more so for development of speech and language. By 6 months of age, we anticipate most children should be able to recognize basic sounds of their native language if they are hearing well. And this period is critical because of what we know as neural plasticity. Just to show you some figures, you have here shown in diagrammatically the amount of synapses that are there when the child is born. Look at the density of the synapses when the child is 2 years of age, because of the excessive stimulation that this child has received and the brain's ability or plasticity to develop new synapses. By 6 years of age, we have something called synaptic pruning happening, and now you can see that that density goes down. So as we know, and this diagrammatically shows it, that the first 2 to 3 years are most critical. This is supported by evidence. We have this very famous paper that was published by the Boys Town National Hospital in the USA, which actually looked at children that were diagnosed less than 6 months of age, and early intervention was done. And those that were identified and intervention was done at more than 6 months of age. And I'm talking of 6 months of gestational age, which is really babies. As you can see, the ones in green, which are those that were identified less than 6 months of age, have caught up almost equal to what a normal child would have caught up. And the ones that were diagnosed more than 6 months of age, it's not that they are not doing well. They do well, but they never catch up with age compared peers. So this study proved what physiology told us, that in effect, yes, this happens. We looked at another study that was done by Gowards P. And what he looked at is that what happens to these children in terms of schooling. When we look at them, children who we intervened at less than 2 years of age, 90% of them were able to go into mainstream education. Those that we intervened between 2 and 4 years, only 60% of them went into mainstream. And older than 4 years, 20% of them could go into mainstream education. An extremely important thing from the Indian context. One has to remember here, education is one of the most important things that every parent wants to give his child. And if we don't intervene early, the chances of them getting any education to be socially independent is going to be very, very difficult. The other term that most people don't know about is neural scavenging, and I'm just going to diagrammatically show it to you. So this is the part of the brain, the one in blue, which is reserved for audition or hearing, and the part in red or orange is what's received for our eyesight. Let's assume for some reason the child's hearing goes down, the child's not getting hearing. What we see now is that gradually that part of the brain that was intended for hearing is being taken over by the eye. And slowly the brain is going to scavenge that part completely that was meant for audition. And this is what happens if we don't use the critical period of time. So after about 3 years to 4 years, that part of the brain that's actually designated for audition is no longer available to us. So the dictum is we either use it or we lose it completely for life. So what is this window of opportunity that we have? As I discussed, the critical period for language education, the first 3 years are optimal for intervention. After that, up to 7 years, yes, suitable, the child will do well, but nowhere near what your expectations as a clinician or a parent is. And beyond the age of 7 years, the outcomes are extremely variable. So when we are looking at now diagnosing these children as early as possible, what are the 3 things we can do in our country? We can either do universal neonatal screening, which is screening every baby born. We can do what's called risk factor screening. That means screening those children who have a high risk of developing hearing loss. Or we can do something called opportunistic screening. So opportunistic screening is the parent comes to you with a suspicion, yes, my child has a hearing loss, and then you screen this child for hearing. The figures next to it is diagnosis. If we were to do universal hearing screening, we are looking at diagnosing hearing loss in children by the age of 8 months. If you're doing only risk factor screening, you're diagnosing them by 16 months or so. And if it's opportunistic screening, that means you're waiting for a parent to bring the child, it's almost 2 years of age. So that is what's going to happen. And based on this, obviously what we feel is that the need of the hour is to thereby develop a universal neonatal hearing screening program. And why are we aiming to do this? We're aiming to do this so there's these children who have a hard of hearing or a hearing impairment, we can maximize their ability to develop communicative skills, more importantly, get good education and be literate. Without these opportunities, these children are going to fall back not in just terms of their language and their cognition, but their social and emotional development takes a big beating. And obviously, all this will result in bad education, less employment, and from the perspective of a country, that is something definitely that's going to impact all of us. When do you screen these children? And what JCIH, which was a Joint Committee of Infant Hearing, in 2007 proposed that you screen children at birth. You confirm it between or before or after 3 months of gestational age, and you have to intervene by 6 months of age. So this was called the 1-3-6 rule. And this is something that's almost followed all over the world right now. However, in 2019, JCIH now recommended that for those places that are already implementing the 1-3-6 rule, we should now move up to the 1-2-3 rule, which is you screen these children by 1 month after birth, you have to complete the diagnostic evaluation by 2 months, and you have to intervene by 3 months. And I'm happy to say that for the last couple of months, KEM, that's Pune, is now moving ahead, and we are trying to do the 1-2-3 rule now in this place. Of course, it's still got challenges, and we've only started implementing it a couple of months back, but we hope that we'll be able to implement it in the near future. The protocol that we follow here is that we do a screening within 3 days of birth. If the child passes, he falls out of the spectrum. If we get a refer, we repeat it after 4 to 6 weeks, because that's when the child will usually come back to the hospital for their first immunization. Again, if they pass, they fall out of the chart. But if it is referred, then the child is then sent for a detailed audiological evaluation and hearing aid fitting, part of which I'm sure Shweta has covered in her talk. What is important are the high-risk babies, and I'm sure most of you who are listening in are aware of all these. The topic of meningitis needs a separate consideration, so I'm going to be leaving that out. And in our study, you will realize that the commonest ones here were birth weight, that was less than 1,500. We had children who had in utero infections as one of our highest causes for hearing loss. The protocol, however, for high-risk babies is very different from those that are well babies. All children who have any of the high-risk criteria will undergo a screening and a detailed audiological evaluation. I have written BERA here, but that is something that is a matter of discussion. The important thing here is that all these children will not only undergo screening, they will also undergo a full detailed audiological evaluation. And that is to rule out a condition known as auditory neuropathy spectrum disorder, which, believe it or not, we are diagnosing much more in the last 3 years than we were diagnosing before, because I think we are looking out for it. The important thing here, which I want all clinicians not to forget, is that even if your child or the child that you have screened has passed the hearing screening, but has at least one risk factor, they should undergo a diagnostic audiological evaluation by 24 to 30 months. And this is now one of the recommendations that JCIH has given in their 2019 position statement. Certain other recommendations that were added in that statement were that any NICU baby that's admitted for greater than 5 days has to undergo a hearing screening. And this admission could be just for observation. It's not that the child has needed any active intervention, but any child who's entered the NICU has to undergo this if the admission was more than 5 days. For any child who does not pass screening in the NICU, as I said before, they should undergo a detailed evaluation. Any screening is always for both years. You do not just do the screening of 1 year if it came as refer. If the child comes back for a rescreening, even if the year had passed in the first test, you will still rescreen that year again. Any readmission in the first month of life also needs a repeat hearing screening. So child got discharged in January, you did a hearing screening, the child had passed in both the years. For some reason, the child came back in the month of February and got admitted into the NICU, a repeat hearing screening has to be done. So you do not, every admission is considered a separate entity by itself. The tests that are used for screening usually are autoacoustic emissions and an automated ABR. The ones on your right are the tests that are used for diagnosis. And like I said, those are very many. The ones that you really need to remember is BERA, that's brainstem evoked response audiometry, also called ABR. And the other tests below that are tests which the audiologist will use based on the age and the cooperativeness of the child. Now, when we look at autoacoustic emissions and ABR, they test different parts of the auditory pathway. So if we look at OAE or autoacoustic emission, that's only testing the hair cells in the cochlea. So all that is giving me information is how the cochlea is working. Whereas the ABR, it gives me information on how the entire auditory pathway is working up to the brain. So both these tests actually give us separate information. OAE, only the cochlea, ABR gives me the entire auditory pathway. Now, when you look at these tests, the advantage of both these tests are they're both non-invasive, they're easily performed, the clinician can test each year separately. Most importantly, we need no active participation from the child. One major difference is for the OAE, you really need the child to be quiet and silent, whereas with an ABR, you can have a child who is not really fast asleep. When we look at now which modality to use, and this is a question that's asked to me very often, the important thing to look is that when you're looking at any screening modality, you should have a failure rate which is not more than 5 to 7%. And any screening modality, you should make sure that it has minimal referral rates. So that's how one is going to look at which one to use. The good thing is both OAE and ABR both have a very high sensitivity to detect hearing loss. But between the two, ABR or automated ABR is much more specific and has a lower referral rate. Also, you definitely need an ABR to diagnose auditory neuropathy, which is one of the commonest things that we are seeing in high-risk infants right now. The advantage of OAE or AABR in a country like ours, where funds is always a challenge, is that OAE is definitely much more cost-effective. But the best combination, if one was to start a universal hearing screening program in their hospital, would be a combination of OER with ABR. And if you look at this study that was again done across the United States, what we are seeing is that the study that used OER with ABR, that was the purple one, someone's in a car, the referral rate was the minimum, which is about 3.1%, and that's what. So we know for a fact that that would be the best one to use. You have to keep in mind certain things, that is that the incidence and severity of hearing impairment is going to increase by 5% to 13% over a 24-year period for these high-risk babies. So please remember that just because a baby is high risk and just because they pass the hearing screening and things are okay for the first couple of years, these children have to be followed up because the chances of them developing progressive hearing loss are very high. So it's something that you need to caution families about and just talk to them about. And we recommend that you should have an audiological evaluation for these children every 6 months for the first 3 years of their life. It's important when you refer children for hearing tests to remember this, that most children who have a hearing loss will present with multiple developmental problems because they also may have other associated issues. It is important that the assessment tool that is used by the audiologist is appropriate for that neurodevelopmental state of the young child. And at least in this hospital, I frankly do not interfere. So if I am referring a child for an audiological evaluation, I do not tell the audiologist, do a BERA, do an ASSR. It is for the audiologist to decide which is the test. They are professionals. They know their job much better than I do. So sometimes I might refer a child for a BERA, whereas the audiologist may be able to give me much more information by just doing a behavioral audiometry. So let's leave it to them. Let's also understand that sometimes a thorough assessment of hearing may require multiple sessions. I know for a fact that a child that I referred for a hearing assessment on Friday, I have got that hearing report only today. It's taken my audiologist and speech language therapist 3 days to evaluate that kid and give me a report. So let's leave it to them and let's not pressurize them that I've sent the kid to you in the morning. I want a report by the evening. Please understand these are children. They have their own moods and they will only give us cooperation when they feel like. So if time permits, do I have enough time? I think so.
5 minutes.
Ma'am, do I have enough time? Should I just quickly go through our KEM study?
Yeah, 5 minutes.
Yeah, that's enough. So this was a study where we've now published it and it should be out in the Indian Journal of Otorhinolaryngology. We looked at our decades experience of universal hearing screening here from January 2008 to 2018. And we evaluated our results. We evaluated about 5,542 babies. Our at-risk babies were much more because this is a tertiary referral center. So thereby the babies that were screened definitely were more that came out of the NICU. The result, what was good was that it showed that definitely those babies that are high risk have a much higher incidence of developing hearing loss vis-a-vis the well-grouped babies. When we looked at the neonatal high-risk factors in our study, the commonest ones that were associated with hearing loss were IUGR, intrauterine growth retardation, birth weight less than 1,500, and hyperbilirubinemia. So these were the results that came out of our study. And the incidence of hearing loss in our study was in the high-risk babies, it was as high as 9.11. In the well babies, it was about 1.49. And our total was 4.41. Disclaimer here is this cannot reflect the incidence in the general population, as a cohort is definitely biased towards having much more population in the at-risk babies. The challenges that we've faced in the last decade have been very many, and they still remain. It takes a lot of time to create awareness in our professional colleagues, both the pediatricians and the gynecologists, as to the importance of early intervention as far as hearing loss is concerned. You need dedicated staff to counsel families, especially at-risk babies. And I'm fortunate that we have Dr. Joglekar and such people with us. The reason being, at that time, the parent is more concerned with the fact that he is taking his child home. That's all they are concerned with. They really don't understand the importance of hearing or other associated problems. And we need special staff to counsel them at discharge. It's not just about having a child who moves all 4 limbs. It's about having a child that uses the brain. And that's what we have to counsel them about. Maintaining records in any hospital are a challenge. So you have a lot of wrong data entries, phone numbers keep changing, addresses of patients keep changing. So thereby to keep a follow-up becomes a big challenge. And in our study, we have a huge number that we lose to follow-up. Listening is not a priority with families. Economics, the cost of setting up a universal hearing program in any hospital, the cost is, the hospital is going to ask you, what is it that they have to gain? So here is where you and your contacts have to kindly look. We are fortunate to have people who contributed to us through their CSR and gave us this equipment for doing universal hearing. In our country, a very unique one is the social customs and stigma. Most girls, ladies will come to their mother's house for delivery, or they stay here for a period of about 1 month to 40 days, and then they go back to their in-laws, which could be in a different city, which could be in a place where they don't have access. We lose out on them. That family doesn't think all this is very important. And that becomes a big challenge then to follow up these people. And of course, non-compliance by the family. That I think is something that you and I can relate to and maybe try and get over by spending a little more time in counseling, which I still feel our unit in this hospital still has to do a lot of work on. It's very important, and I think this is almost my last slide, to remember that just doing hearing screening is not enough. If you do hearing screening, you have to still have the infrastructure to constantly monitor these children systematically for their language development, to conduct additional hearing screening. And more important than not, if you diagnose someone with a disability, you and I have to have a plan of action as to how that family is going to deal with that disability. Just telling someone, your kid has a disability, and stepping back is not enough. So setting up the resources, as we've done here in KEM in the TDH Center, of not only intervening early, but seeing these children through the entire process and seeing that they become productive members of society is very, very important. It's important, and this comes from the American Association of Pediatrics, that you have some sort of a periodicity schedule. So you have the important things like developmental milestones, auditory skills, and parental concerns assessed at 9, 18, 24, and 30 months of every child. The way we look at, does the child turn over? Does the child smile? We need to do this so that we miss out lesser and lesser. And for God's sake, listen to the parents. It is disheartening when, as an ENT surgeon, I have a parent telling me, I was telling my pediatrician that my child is not hearing, and he or she said, "Wo to sun lega." He will hear sometime in the future. Parents definitely are the first ones who know there's something wrong with their children. Let's listen to them more. And there's no harm in getting a test done and telling them, look, things are okay or not okay. All of you, I'd urge you to read this consensus statement that was published by the Indian Academy of Pediatrics on newborn hearing screening. It's an excellent paper, and it gives you a lot of information. So all of you out there, kindly read this. And when our paper is out, published, I'll share it with Dr. Chaudhary, and she can share it with all of you. Thank you so much for your attention. It's been great interacting with all of you virtually. My apologies again for being delayed. Thank you so much, Dr. Chaudhary, for this opportunity.
Hello, ma'am. Hello.
Yeah.
Great talk, ma'am. Thank you. Just
Thank
have
you
a
so
question.
Yeah.
This is Dr. Rani Bashir. I'm a neonatologist from Cochin. So my question is like for extreme preterm babies and all, like is there a particular age group? Is there a particular corrected weeks of gestation where we should be waiting till we do the BERA test, or any time before discharge should be fine?
So originally that was Dr. Rani, what they had recommended. They had said that, you intervene or you do a BERA test at 3 months of gestational age. And for quite some time, we followed that. However, now the new recommendations are that at NICU discharge, maybe you will do a screening and you can do a BERA within about at least a month of that. So that corrected gestational age now doesn't exist anymore. But I do agree with your point. That is what was said. But one has to remember, Rani, that at this point, you are not going to be telling the patient or the family that there's hearing loss. We're going to be counseling them. We're going to be saying, we are following up this kid. So I would say ideally as soon as possible. However, if you really want to be safe, then 3 months of gestational age.
Okay. Ideally 3 months. Okay, ma'am.
Yes,
okay.
Ideally 3 months. It's only because, one has to understand that BERA is not a test of hearing. That's the first thing that I think you need to put out there. BERA is a test of neural function. And in a preterm child, as we all know, neural development is going to take time. So what will happen is if you're going to keep doing repeated BERAs very early on, you're going to get them failing because the brain is still developing. And then you're going to have to keep justifying to the family. And the family sometimes get angry saying, but you told us our child is not hearing. How is the child hearing later on? So to save you from that, I would say all your preterms, all your NICUs, better to stick with 3 months of gestational age because you're giving the brain that much time to develop. BERA tests nerve conduction. It doesn't test hearing. The actual test of hearing is behavioral observation, which is done only by very experienced pediatric audiologists, and it takes a lot of time.
Okay, ma'am. Thank you so much.
So I have a couple of questions in the chat. I have before 37 weeks, can we screen these babies? Yes, screening can be done at any age. Basically, you're going to do it when the baby graduates out of the NICU. That's when you're going to do your first screening. Just to take it from those of you who didn't hear it, there was a question about when do we do a diagnostic test of evaluation for these children. I think for preterm babies, it would be best if you do a diagnostic evaluation after 3 months of gestational age. Have some questions on the doc.
No, I'm not communicating.
Okay, this is already answered. Shweta has answered, yes. Oh, I'm so happy. Shweta is answering all my questions. There's a question as to at what time should one decide to go for a cochlear implant in a newborn? Ideal time. Mr. Amit, I don't think anyone does a cochlear implant in a newborn technically. For the process for cochlear implantation is pretty long. You have to undergo a detailed audiological evaluation. Post that, you will be giving the child some sort of amplification device like a hearing aid. The child is then followed up with the use of a hearing aid for at least about 3 to 6 months. And if after that we see that the child is not getting benefit, it's that time that you start discussing a cochlear implant. So given that scenario, I would say in India, the earliest that I have made decisions about cochlear implant in children is about between the age of 9 months to 12 months. That's when you can say, okay, this kid may be a candidate for cochlear implantation. The FDA, both of the US and of India, as of now, have given us permission to earliest implant children at 12 months of chronological age. Having said that, if the child is syndromic or if I have meningitis, that means the child has meningitis, or if there is an elder sibling who's already implanted, we can think about implanting them at less than 12 months of gestation, of chronological age. The earliest one that we've done in our hospital is a 10-month-old child. But this is something that one can do, but I would say legally it would be 12 months. I think that ended with one more message. How do I go down? Ah. Mhm. Okay, that's it. I don't think there were any more questions, right? Beyond this, no, this was something milestones.